and I've enlarged this just a little bit. So from that distance to there is back, and then this big one is probably from here to here, and then this is the small one. So does this make sense to you as you look at the capillary network? Remember I told you that fast glycolytics, when they make a lot of additional force, they really don't think oxidative metabolism. They don't think mitochondria. Well, that's reflected, by the way, that's probably a precapillary sphincter right there. But see, they have a very meager blood supply compared to, it's funny, this one is intermediate in size because you really can't make a guess. Is that a fast oxidative, what is that? Well, whatever it is, it's either a fast oxidative glycolytic and their owner trains a lot, or it's a rather large slow oxidative, but its capillary investiture is very rich. So whatever it is, it does a lot of oxidative work for a living. Yes, sir?
Is that why they say fast switch fibers or white fibers?
Yeah, that's right. They're myoglobin content, the thing that gives, Jay, turkey, Thanksgiving is coming, an American holiday. The brown meat is slow twitch fiber. The brownness color, the dark meat, reflects its mitochondria content, mitochondria are brown, and myoglobin gives a brown-orange color. So, I was talking to someone, Adelaida, about fat dropules. I was talking to someone about fat dropules. The dark meat, because it's focused on oxidative metabolism, is a little bit richer in oil droplets. That's why the dark meat is moister and more tasty. The dry white tissue is what the bird uses for flying. If you know about turkeys, they're sprint flyers. You don't admire the turkeys migrating. The turkeys, will sprint in the hide in the bush. Yes. All right. So here's the part I want to get to. I'm jumping to the end of the circulation. The veins. Veins are large, floppy, meaning high compliant vessels. Very little ability to vasoconstrict. They do, however, especially the peripheral veins in the large muscle-covered limbs, have valves on them. And these valves are unidirectional. Leonardo da Vinci knew this. The valves all resist flow out, and they allow flow in towards the heart. Now at rest, there's not, remember I told you the pressure in these segments is like 7 millimeters of mercury, so it's very slow trickle. The way that you might enhance flow back to the heart is because most of these peripheral veins are buried in muscle. If the muscle begins to contract, it pushes in on the vein. It pressurizes this segment. These valves will slam shut. The only place that this pressurized blood can go is home. And that's called the venous muscle pump, and that's going to be incredibly important. I'm hoping to make the transition to exercise today. It turns out that's one of the hidden mysteries of how does this system work during exercise, because you've got to get some giddy up in the venous blood, or it's never going to get back there. So to finish off at rest, let's talk about determinants of venous return. So you would think that you could describe it by just using the whole arterial systemic circulation. How do you say this? The American River, if you tried to describe its flow characteristics down at Discovery Park where it runs into the Sacramento, it's a huge broad river, massively deep. There is the altitude change per mile is probably a foot. So the flow of the American River at the end of its journey is remarkably sluggish. If you were to go up in the Sierras and measure the height change per mile, which is huge, narrow channel, big vigorous, turbulent river, you can't use the systemic side numbers to describe venous flow. That's what I'm trying to tell you. So to understand venous flow, we have to go to the venous side. But we have a flow equation. Flow is equal to a driving pressure difference divided by a resistance to forward flow. So this is cool. We just got to generate these numbers on the venous side. I've told you now that the driving pressure is about 7 millimeters of mercury at rest. The right atrium has a pressure generally at rest around 0. So that's nice because 0 drops out. So basically, whatever the pressure in the venules is going to be the pressure that sends it home. A good thing about the resistance of the great veins, I told you they're very large vessels, and they don't have enough muscle in them to actually change their resistance. And so the bottom of this equation, the resistance great vein, it's there, but it doesn't change, and so it drops out too. So it turns out, what is the determinant of venous return in a resting human? The pressure in the venules. Is that okay? So you're not used to looking at it that way. Oh, by the way, this, what I call the pressure in the systemic venules, the pressure in the systemic venules, this unfortunately has like 4 different, every time someone rediscovers this principle, they give it a new name, and it's always bad. So I'm sorry that you have to learn 4 or 5 different names, but if you just back off from terminology, a rose by any other name would smell as sweet, said Shakespeare. Just say, you know, the driving pressure that sends the blood home out of the venules, they'll understand. So, here's what I just told you. That venous return is created by the pressure difference because the resistance to flow doesn't change. The primary determinant of venous return is this pressure difference, and usually the right atrium is polite enough to stay about 0. So this becomes really easy. The thing that creates venous return is the pressure in venous. Is that okay? And be brave. This is one of the hardest intellectual things we'll do today. We do not have, well, you can build this graph, and it is absolutely dead true. The problem is, if you are hoping to make direct measurements of the pressure in the venules, you need yourself several trillion hair-like perforators, and you've got to put them in the venules scattered all throughout the body. It's not happening. Right? You cannot directly measure this. So this is the graph we have, a venous return graph, the same units on the y-axis. This is venous return. We normally have cardiac outputs of 5 at rest, so this is the normal 5 liters per minute. Unfortunately, notice what the x-axis is here. It's the right atrial pressure. What kind of crazy crap is that? You're graphing the phenomenon by the thing that destroys it. You're graphing it by the back pressure. Why would anyone do that? Because you can measure it. It is quite easy, as I said, to slide the catheter into a vein in the right arm, get it through the subclavian and into the right atrium. That is measurable. The peripherals aren't. Now watch how clever. I'm not this smart, but I'm sure glad someone was. Once you have that catheter floating in the right atrium, you could seize control of the atrial pressure, because it's a tube, right? I can pressurize saline and shove a liter, half a liter of fluid into the atrium and cause its pressure to go up. Okay, well, if I increase the back pressure, thereby destroying the gradient, the higher I artificially elevate the right atrial pressure, the more venous return drops. Does that make sense? Okay, now hang on, because this is just awesome. At what point will total flow out of the vein cease if this gradient is what makes it happen? When will it stop altogether? When the pressure in the right atrium equals the pressure in a trillion tiny venules that could never be measured. And so the x-intercept of these curves, this is how we learn what the pressure was in the peripheral venules. Notice how that's 7? I've been telling you that the pressure in the peripheral venules is 7. How do I know that? Because when I artificially inflate the pressure in the right atrium to 7, this gradient becomes 0 and all flow out of the vena cava terminate. You can do that. This study's been done multiple times in animals. It's called stop flow. The animal doesn't even die. You just drop the pressure, or you pull the fluid back out. The animal's fine. Does this all make sense? Okay. Good for you. Sorry you had to see that, but if you go to grad school or medicine, you're going to see those. So to finish up last lecture, in a way, we're kind of stuck. I want to point out, I've just told you, we already mentioned, this is a Frank-Starling curve. We've already mentioned that the stretch, remember the stretch in the right atrium directly affects how big the atrial contraction is into the right ventricle, and that stretches. And so that the right atrial stretch actually carries all the way through the heart. If you have an elevated right atrial stretch, you have an elevated left atrial stretch, for the most part. So this is a Frank-Starling curve. The more pressure, the more distending, more stretch, the better the cardiac output, right? Realize what I just told you about venous. So hearts like stretch in their atria. Do vena cavae? No, vena cavae hate pressure in their atria. And so you wind up with sort of a very interesting, these are like squabbling spouses arguing about the thermostat setting, that there can only be one temperature in the room. And so it turns out that you have to have a low enough atrial pressure to optimize the venous return. You have to have a high enough stretch on the atria to get an adequate cardiac output. And so this is what I call the box of rest. At rest, that's how we regulate. Now, watch what the problem's going to be, because we're just going to start to talk about exercise, and you think, it's easy. I just stretch the atrium. And that works great for increasing your cardiac output for about 3 seconds. You see what happens to the problem? You collapse the venous return, the vena cavae slams shut. And so the reason I call this a box or a trap is you have to totally reinvent the circulation if you would like to double your curve. You need a new circulation. If aliens came down and studied us at rest, they would have a hard time understanding how we can exercise, because all the parameters of the system are trapped at that. Okay? So let's go up to, let's go starting to exercise. And